Hey, thank you, Carly, for starting the recording. Let's I would like to just start right on time so that we can slate enough time for Dr. Jeong to go through all of his didactics and cases. So good afternoon, and before I begin, I would like to let everyone know that this session is being recorded, and these recordings will become available on our website after the session. We are very excited to have all of you join us for the 10th DENT Echo session. We have a wonderful didactic and case presentation lined up for you today. My name is Kato, and I will be assisting in facilitating today's session. For those who may be new to ECHO, this is a model that builds virtual communities of practice and learning. Sessions begin with a didactic presentation, followed by a identified case-based learning and group discussion to foster deep knowledge and build individual capacity. Before we carry on, I will ask Carly, our UT ECHO IT for today, to share some guidance about your audio connection.
Hi, please stay muted unless you're speaking. You can mute or unmute using *6 on your phone if called in, or the microphone icon on the bottom left of your screen if you join on the computer. You can also communicate with the chat feature. Please remember that no personal health information is allowed when discussing cases and scenarios. Thank you.
Thank you for that, Carly. I would like to move on to introductions. If I call your name, please let us know a little bit about yourself. First, Dr. Chala.
Hi, thank you all for being here. I'm Suman Chala, Associate Dean for Advanced Education Programs at UT Health San Antonio. And we're delighted to have you all of you here. Thank you.
Thank you. Dr. Aguilar.
Hi, good afternoon, and thank you for joining. I'm Rosalie Aguilar. I'm a co-director along with Professor De La Torre of DENT ECHO, and also a program coordinator for the Holistic Oral Health Program for Elders, which is also under the direction of Dr. Chala here at UT Health San Antonio. So we're excited you're joining us here today.
Thank you. Professor De La Torre.
Hello, everyone, and welcome once again, those of you as you join. My name is Magda De La Torre. I'm on faculty in the dental school and co-director of DENT ECHO.
Thank you. And Dr. Jeong.
Hello, this is Dr. Jeong. So I'm the one who is supposed to give a presentation today. So hi, everybody. So you want me to start right now?
Not yet. Thank you. I would do some announcements and then I will prompt you to start, Dr. Jeong. Thank you so much for that. And to move on to some announcements, to everyone who's joined the session, please enter your name, title, and affiliation into the chat to help us with attendance and so that we can get to know each other through chat. If you haven't already completed the pre-session questionnaire, you can do this now using the link I believe Dr. Aguilar had shared in the chat. And to receive CDE credits, registration is required through the UT Health CDE website. And also that link, if you could, Dr. Aguilar, if you could share that link in the chat as well. And also, we will follow up by email with instructions for completing the post-session evaluation and attaining your credits post-session. And ECHO is an all teach, all learn supportive model, and ECHOs thrive on the interaction from the full learning network. So I encourage everybody to participate in the conversation today. We also encourage you to join by video if you can, so that we can see your faces, especially during the discussion portion of the session near at the end. And our session today will include a didactic and case presentation from Dr. Jeong. And the title of the didactic is Full Mouth Reconstruction in Prosthodontics. And as a reminder, you can use the chat to raise questions and comments at any point during the session. Dr. Jeong, I believe Carly already made you a co-host. Whenever you're ready, you can start sharing your slides and please take it away.
Thank you. I think from the beginning, so I have a little bit problem. So I made this presentation for 55 minutes. Then I expecting 5 minutes for discussion session, but I didn't know that we have a 5 minutes introduction. So we'll see. I'm trying to go faster. So, okay, I want to share my slides. So can you see my slides?
Yes, we can.
Okay. Okay. Good afternoon. So thank you for joining the Dent Echo seminar. So I would like to say thank you to Dent Echo team to invite me as a guest speaker today. My name is Dr. Cheol Jeong. So currently I'm working for University of Texas Health at San Antonio School of Dentistry. I'm honored to share my experience with you today. A month ago, I received one email to ask me about 1 hour lecture. Because I'm currently the interim program director in graduate Prosthodontic program here. As you guess, not easy to say no, so that's why I'm here. The topic we are going to talk about today is full mouth reconstruction in prosthodontics and case presentation. So when you hear full mouth reconstruction, so what things are coming to you? Probably, oh, can I do it? Who will be the best dentist I can refer to? Something like that. Because the full mouth reconstruction case itself is really challenging. As you already know, so I'm going to give you 30 minutes didactic course at the beginning, and the rest of the time will be my case presentation. Again, the title of today, full mouth reconstruction in prosthodontics, is a really big topic. It's not easy for me to cover everything in 1 hour, but I'm trying to make it as simple as I can. So these are the objectives today. So we will discuss about what is a full mouth reconstruction in dentistry, especially in prosthodontics. Also, we keep talking about central relation, vertical dimension among dentists. So what they are. Also, we are going to talk about the techniques to determine vertical dimension and central relations. And then definitely we are gonna see some cases. Okay, then what is the definition of full mouth reconstruction? Everybody knows what it is, but I tried to look up the perfect definition of full mouth reconstruction in the glossary of prosthodontic term, but I was not able to find that out. So I just Googled it. This is one of the definition online. Full mouth reconstruction combine aesthetics with the science of restorative dentistry to improve the health, function, and the beauty of the mouth by rebuilding, replacing all of the teeth in the patient mouth. So make a long sentence short. It is a saying full mouth reconstruction procedure will give the function and aesthetics back to patient. I would like to add one on top of this definition. My personal definition is to re-establish patient vertical dimension and central relation by replacing missing teeth and lost surrounding tissues. So by doing so, patient will have their function, aesthetics, smiles, and confidence back. So then what kind of dental procedures can be performed for these procedures? We are the like a restorative dentist who does treatment planning and fabricate crowns, ornates, veneers, implant crowns, IPDs to finish the full mouth case. As you know, in order to take care of this complex case, we need all other dental specialties. We need a periodontist who will take care of soft tissue around the tooth, and they will place implant, so with the bone graft. Also, we need an endodontist who will do root canal treatment for us because some cases require elective endo treatment, and some teeth need a casting post as well. Full mouth reconstruction also requires orthodontist to move teeth in the favorable positions. Also, a few patients may be present may be presenting with a maxillary and or mandibular skeletal discrepancy issues. So then we need oral surgeon to correct the jaw relationship for us before we start our procedures. I have not done any full mouth case with a pedodontist yet, but if someone who was born with congenital abnormalities with a medical syndrome, and when they are growing up, they may be candidate for full mouth reconstruction to fix either function or aesthetics or both in the future. So then we should be able to communicate with their pedodontist or their primary dentist to figure out some information to reconstruct the patient mouth. Also, we need temporomandibular joint specialist and the sleep apnea specialist as well. A patient who has a temporomandibular joint disorder, they need to be taken care of before we treat those patients. If you see any pathologic findings during your comprehensive examination, you should refer patient to oral pathologist first. Then we can start to see patient. So then, why we would like to reconstruct the patient mouth? Basically, two reasons, right? Function and aesthetics. They want to do better because some patients lost their teeth, whatever reason was. Some patients may present with a severely worn dentition. So aesthetics, due to the missing teeth, severely worn down teeth, malaligned teeth, discolored dentition, overclosed mouth, like a slanted occlusal plane, unfavorable occlusion, and the other different reasons. They wanna look better. Some patients do not feel comfortable to talk with other people because they think that they do not have a prettier smile. So for example, they are covering the mouth with their hands when they talk or smile with other people. It is not common, but there are few people who have congenital issues like amelogenesis imperfecta or like a dentinogenesis imperfecta. Those cases may be also indicated for full mouth reconstruction, depending on the how bad, how good it is. Also, some people may have acquired abnormalities like a trauma, cancer tumor, so which required some type of facial reconstruction, like a fibula flip flap. So this is one article which was written by Dr. Turner in 1984. This article title is Restoration of the Extremely Worn Dentition. I think that this is a great article to explain how to classify a patient who needs full mouth reconstruction. Basically, this article divides patients into 3 different categories, depending on whether there is space to restore. So based on Dr. Turner's article, category 1, 2, 3, so we are going to look at each category one by one. A typical patient in this category, has a few posterior teeth and unstable posterior occlusion. There is well of anterior teeth, closest speaking space of 3 millimeter, interocclusal distance is 6 meter. So there is some loss of facial contour that results in drooping of the corner of the mouth. This is a relatively easy case. It doesn't mean easy, but relatively easy compared to other categories 2 and 3, because we should be able to raise the vertical dimension in order to create more restorative space. Based on Dr. Turner's article, category 2, patient has adequate posterior support, history of gradual wear. However, because of continuous eruption, we say passive eruption, vertical dimension has been maintained. Due to the passive eruption with the tooth wear, interocclusal space is not sufficient for restoration. So manipulation of mandible into central relation will open often reveal significant anterior slide from central relation from the back to the maximum intercuspation forward. Closest speaking space is millimeter. Interocclusal distance is 2 to 3 millimeter. So continuous eruption has maintained the vertical dimension again, leaving insufficient interocclusal space for restorative materials. This is not as easy as category 1, but still we can gain maybe a couple of millimeters to restore. This is the tunnels like a clarity. This is the hardest one. Posterior teeth exhibit minimal wear, but anterior teeth show excessive gradual wear over the period of time. Central relation and central occlusion are coincidental. With the closest speaking space millimeter, interocclusal distance is 2 to 3 millimeter. This category is the most difficult to treat because vertical space must be obtained for restoration. We cannot open up the vertical dimension. So this case is really challenging because of that, because we should restore the case at the current vertical dimension. What Dr. Turner told, that this category requires a surgical crown lengthening and also treatment, which is intrusion, until we can get a space to restore. It is not common, so sometimes we are taking the teeth out to restore. So then why are teeth wearing down? So there are many reasons of tooth wear, but so majority of tooth wear are coming from attrition, abrasion, erosion, and parafunctional habit. You already knew so what they are. So attrition is a tooth wear by tooth contact. Abrasion is a mechanical tooth wear like a toothbrushing. Erosion is a kind of a demineralization by the acid, like a gold. Lastly, parafunction is another big etiology of tooth wear, like a bruxism or clenching. So we briefly talk about the definition of full mouth reconstruction, etiology of the tooth wear, objectives of full mouth reconstruction, and classification of severe wound dentition. In general, when your patient works in the clinic, this is how we are treating a patient. The way of treating of the full mouth reconstruction is exactly the same. Diagnosis, treatment planning, treat the patient. So we move on to our maintenance page. So when you have a new patient, a diagnosis is one of the most important steps, because if we do not have concrete diagnosis, we cannot do treatment planning, and we cannot treat the patient. In order to get to that, like a diagnosis, we are listening to the patient's chief concern. We do comprehensive examination, taking medical and dental history. Also, we taking radiographs, like a full mouth series X-rays, panoramic X-rays. If needed, 3D cone beam CT, so will be taken as well. Another one is pre-treatment photographs. These are really important in order to see before and after at the end of treatment, especially for full mouth reconstruction case. So once we collect all the information from the comprehensive examination, we should be able to do treatment planning based on what we collected from those information. Again, in dentistry, one of the hardest steps is treatment planning, because there are more than one treatment possible. So that is why comprehensive examination is crucial, and why communication and patient education are essential before we start the treatment. Another helpful step is to get to the diagnosis, is to take diagnostic impression, Facebook and central CR record. We should be able to mount the diagnostic cast on the articulator with the Facebook record and the CR record. In general, they will be a great diagnostic tool, because we can see that on the articulator extraorally. We cannot see everything intraorally. This is an example of a diagnostic cast. We can see that each individual tooth and tooth relationship extraorally. Also, lingual side can be seen on the articulator as well from the back. So we can have better pictures to do treatment plan. During the treatment planning, we do diagnostic wax up on it. on them. This diagnostic workshop is a great tool for us to estimate the final restorations, and to educate the patient. Let the patient see, understand how they look like at the end of the treatment. This is another example. A bite registration was taken at a tentative vertical dimension in order to make modified Lucia jig, which can deprogram the muscle activity. Diagnostic workshop was completed with a new CR bite registration, and you established the vertical dimension after muscle deprogram. This is just another example. Again, I cannot tell how important the diagnostic workshop is before we start the treatment. As we talked about, diagnostic workshop is a tool to visualize the results of a prosthetic case to patient prior to the treatment initiation. With the diagnostic workshop, we can get a lot of information about tooth preparation, axial wall height, crown retention, and etc. Also, we can tell whether clinical crown lengthening is needed or not by looking those like a diagnostic tests. Another benefit with the diagnostic workshop is we can make a putty mold for making temporary crowns and making suck down shell for making reduction guide by duplicating the diagnostic workshop. Before we move on, I would like to make sure we know the differences of these terminologies: centric occlusion, centric relation, maximum intercuspal position, and the maximum intercuspation. When you ask our colleague, what is the centric relation? Maybe higher percentage of dentists answer like this: the most anterior superior jaw position. Depending on when you graduate from your dental school, your central relation position may be the most superior, maybe the most posterior superior. So yeah, either one is correct, but that is not what I wanna know about today. Centric relation is not tooth relationship. Basically, centric relationship is independent of tooth contact. In other words, this is a maxillomandibular relationship. Also, based on research, centric relation is a musculo-skeletally stable position. Centric relation is determined by the temporomandibular joint structure. The most important thing, this is the keyword. Centric relation is reproducible or repeatable. That is the most important keywords. Basically, centric relation has the axis of rotation, and the centric relation has the same arc of closure. There are a lot of things to discuss about centric relation itself, but we have limited time, so I'm going to move on. Again, centric relation is a reproducible, repeatable position. Okay, now we have a centric occlusion. We do not often use this term centric occlusion, but we still should know what this is. The centric occlusion is the occlusion of opposing teeth when the mandible is in centric relation. This may or may not coincide with maximal intercuspal position. Then what is the maximal intercuspal position, MIP? This is the complete intercuspation of the opposing teeth, independent of a condylar position. This is tooth-to-tooth relationship. Maximum intercuspation, this is trickier thing. I look at the glossary of a prosthodontics term. I cannot find that out, but I Googled it. So unlike a maximal intercuspal position, maximum intercuspation refers to the position of the mandible when teeth are brought into full interdigitation with the maximum number of teeth contacting. Make it short, this is a jaw relation when teeth are in MIP. So now let's look at the techniques, how to guide the mandible to CR. As you see, there are 12 techniques in this slide, but there must be more than 12, but we cannot go over everything. I think the first 4 techniques are the most popular techniques among dentists. Bimanual technique by Dawson, so anterior guidance by Lucia Zieg, anterior guidance by lift gauge, and Gothic arch tracing. So whichever CR technique you choose, the bottom line is to deprogram the muscle memory first before you take central relation, bite restoration, because most patients have reflex closure guided by the teeth. So ask the patient to bite on anterior jig or lip gauge with anterior teeth for 5 to 10 minutes. So we believe muscle memory will be lost. In 1973, Dr. Dawson introduced this bilateral manipulation method. Basically, this technique, the condyle head can be guided into superior position in the gradient fossa. It said the condyle is within 0.02 millimeter accuracy 3-dimensionally, but as we discussed about the concept of central relation is located the most superior anterior position. But this technique is to guide the mandible into superior position. Some dentists still using this bilateral manipulation technique, but interestingly, this technique still works. So I don't know why, but definition is a different, but technique is the same, but still works. The second one, so the Lucia Zieg technique, anterior jig, this occlude posterior teeth. So it disrupts the proprioceptive memory. In other words, anterior stop breaks patient habitual closure pattern. After masticatory muscle was deprogrammed with anterior Lucia Zieg, so posterior bites on both sides will be taken with anterior like a Lucia Zieg. The third one, 1973, Dr. James Long introduced the lip gauge technique first time. This is the kind of the most useful and the practical alternative to anterior jig. So they are convenient, measure the exact vertical openings between the incisors because each lip gauge has a uniform 0.1 millimeter thickness. Sometimes, whatever reason, with our technique, patient's side, it is really hard to guide the patient mandible into central relation position, then this Gothic arch technique will help. In 1910, so over 100 years ago, Dr. Gissi introduced this Gothic arch technique. As you see this slide, the recording plate, we say central bearing plate is attached to the maxillary arch, and the central bearing pointer will attach to the mandibular arch. When mandible is moving into protrusion and the lateral excursion, those movements will be recorded on the central bearing plate on maxilla. You can see the duck feet, the bird feet on the right picture. So can you see one dot on the plate? This dot is the centric relation where 3 lines meet together. So, okay, let's talk about vertical dimension now a little bit. So vertical dimension is the distance between 2 selected anatomic or the marked points. It's usually one on the tip of the nose and the other one on the chin. As you know, in general, there is a 2 to 3 millimeter freeway space for skeletal class 1 people. So in other words, rest vertical dimension. We used to say VDR, but the RVD is like a right term currently. Is 2 to 3 millimeter taller than that occlusal vertical dimensions. There are different ways of determining rest vertical dimensions and the occlusal vertical dimensions. Again, there are a lot of different techniques. I just want to skip them. So there are too many things. So instead, I would like to talk about Dr. Silverman's closest speaking space methods. This is the technique I'm using in general for my patient. It's a pretty simple technique as long as you know what you are doing. In 1955, Dr. Silverman proposed this technique. He identified the production of certain sounds like S, yes, ts, brings the anterior teeth very close together, very closely together. So what that means, when your patient pronounce a sibilant sound like a 66, 33, listen to the sibilant sound carefully and then look at the teeth relationship intraorally closely. By listening them, looking at them, looking at the upper and lower incisor, like even posterior relationship, we should be able to tell vertical dimension is tall or low. In other words, in teeth are contacting each other during that time, it means vertical dimension is tall. So we need to reduce the vertical dimension. If there is too much space during that time between the mandible and the maxilla, so it means the vertical dimension is low. In other words, we have a little bit more room to raise up. So here is another simple and easy technique. In 1955, Dr. Shanahan proposed this technique. Basically, when we swallow it, teeth come together with a very light contact at the beginning of the swallowing cycle. So a patient feels difficult to swallow it, which means the vertical dimension is tall. Vertical dimension needed to be adjusted. Personally, I'm using this technique to verify my vertical dimension. Increasing occlusal vertical dimension. Why, when, how? So this is another hard topic. As we discussed about Dr. Turner's classification already. So when you treat the full mouth reconstruction case, so one of the important factors is whether we consider the factor that we should consider is whether we can raise vertical dimension or not. Based on some evidence, vertical dimension is not related to the temporomandibular joint disorder. There is no evidence nor suggest by changing vertical dimension one can treat the TMD. But vertical dimension can be raised or closed for the best function and the aesthetic, as long as the range of the change is within physiologic limitation. Vertical dimension can be raised for every full mouth reconstruction case. That's what I found, but I do not agree. So I do not think that we can raise the vertical dimension for every single full mouth reconstruction case. So this is another article by Dr. Di Pietro. The title of the article is the Significance of the Frankfurt Mandibular Plane Angle to Prosthodontics. The purpose of this article, there are three purposes, but I wanna just focus on the last one to point out the applicability of this knowledge to prosthodontic diagnosis, treatment planning, and prognosis. So this is one table from that article. As you see this slide, FMA. Sorry, that will be the next slide. As you see this slide, FMA is an angle formed by the intersection of the FMA, the Frankfurt horizontal plane, and the mandibular plane. 25-degree FMA is a standard for orthodontists, plus or minus 5 degrees within normal range. So if MA is more than 30 degrees, it is open bite skeletal pattern. If FMA is less than 20 degrees, it is closed bite skeletal pattern. When you look at the clinical manifestations of high and low FMA patient, first line, biting force. Low FM shows increased biting force. Fourth line, masticatory muscles are hypertrophic. So what that means, someone who has overclosed mouth or severely worn down dentition have strong biting force. By doing, by raising the FMR, biting force will be decreased. So what I'm trying to say basically, so reconstructing full mouth with a slightly raised vertical dimension will be beneficial to decreased biting force. Whenever mouth is overclosed, jaw relationship will be class 3 because of axis of rotation. On the contrary, when mouth is opening, jaw relation will be class 2. In other words, when a patient comes to your office with the overclosed vertical dimension, we will expect the patient-jaw relation will be edge to edge or cleft-free tendency. Also, you may expect a well-developed mesenteric muscles. We can see similar situation in complete denture patient who wears upper and lower complete denture for a long time. Denture anterior relationship becomes either edge to edge or a cleft-free relationship. When all your treatment is completed, maintenance phase is important. After completion of treatment, follow-up appointment is essential to monitor the hard tissue, which is gum, and the hard tissue, teeth, crowns, and the soft tissue, which are gums, and identify the incipient disease. During the regular follow-up appointment, oral hygiene instruction needed to be reinforced, and the scaling is recommended to maintain gingival health. Also, margins of restorations must be evaluated both clinically and radiographically. If needed, oral hygiene aids needed to be prescribed, like chlorhexidine solution and then Prevident toothpaste. So in medicine, the goal is to increase the lifespan of the functioning individual. Our goal in dentistry is to increase the lifespan of the functioning dentition. So, okay, so I think it's just slightly over like 30 minutes, but now I'm gonna share some clinical cases. From 1 to 6 is a pretty simple, straightforward. The last one is a little bit long, so let's start. So as we discussed about, one of the definition from our reconstruction was to re-establish the vertical dimension and central relation. So I consider conventional complete denture is a kind of removable full mouth reconstruction. So what I'm trying to emphasize is, if you want to treat the full mouth reconstruction case by yourself, you should be confident to take care of the conventional complete denture case. The objectives of the full mouth reconstruction are function and aesthetics, as we discussed above. As you can see this slide, she had a new maxillary and mandibular complete denture made. She can eat now, so she can smile. So this is another conventional maxillary mandibular complete denture case, but patient has a couple of dental implants placed for better retention. Currently, standard care for mandibular complete edentulous arch is to implant retained over denture. So same thing, he can eat it now, so he smiles. So this is one of my implant supported mandibular complete denture patient. The reason I added this slide here, can you see the difference between two pictures? So when you set the denture teeth, we are trying to set the teeth in neutral position or over the mandibular alveolar crest. Also, there is a good guideline, pound triangle. The teeth set up on the teeth left side were set based on the general guideline. But patient was not able to tolerate when he opened his mouth. So we ended up moving on his mandibular left molars lingually. You can see that on the slide on right side. You can see the modification on the right side. So, sorry. So two pictures on the top show my initial vertical dimension based on my knowledge. However, patient complained his cheek on his left side was too tight, sore. I end up close the vertical dimensions. So two pictures on the bottoms are after I close the vertical dimension. There is almost no vertical space for patient molars. Why? This is why he complained about his position and vertical dimension. He had a burn on his neck and face, especially on patient left side. So his facial and masticatory muscles cannot stretch enough to tolerate regular vertical dimension and regular tooth position, normal vertical dimension, normal tooth position. So as you saw on the previous slide, I ended up close the vertical dimension and move the teeth position to the lingually. So he may be complaining of biting tongue at the beginning of the prosthesis insertion later, but that is what I can do for this patient. So a tongue is a quick learner, so his tongue will figure it out, how to manage it. This patient had a 6 implant placed for maxillary supported fixed complete dentures. During the osseointegration, he had a severe car accident. Unfortunately, 2 mandibular condyles were replaced with artificial condyles, and the lower teeth were extracted due to the accidents as well. So 6 more implants were placed for another mandibular hybrid prosthesis. You can see the series of panoramic radiographs. Because artificial condyles, his jaw allows only rotation, movement, without like a translation. So basically, I did not really have to guide his mandible into centrulation because his jaw movement is only rotation, centrulation, repeatable and reproducible. I do not recall exactly this diagnosis right now, but it seems like the osteoradio necrosis in the middle of the mandible. His mandible was resected and reconstructed with the pivotal pre-flap. But as you see, the surgeon was able to keep number 18, number 31 implant. Because his vertical dimension was maintained with the existing number 18, number 18 and number 30 implant crowns, just by taking new century relation record, his mandible was reconstructed, easier for us. So this is the case when I final prosthesis was when I delivered the final prosthesis. Previous 2 implants were splinted with a new implant as part of the implant that supported the fixed complete denture. Also, you can see the space underneath of the prosthesis for clinic purposes. This is another hybrid case, maxillary complete denture and the mandibular hybrid detached prosthesis. So this is another case. So the reason I put those like cases, I just want to emphasize, please enjoy seeing the complete denture patients. So that's what I'm trying to share with you. So this is my last clinical case. I'm gonna spend most of I will spend the rest of my time. This is my first full mouth reconstruction case during my residency. So it is not case. Please do not criticize a lot. So, but I would like to share case with you. This gentleman, QD, presented to the clinic. His main concern was, so my teeth worn out. I'm interested in making them look better, and I want to chew better. So his priority was aesthetic among function, comfort, longevity, and cost. He's willing to invest his money to make him look better, and chew better. So he's a non-smoker. He does not drink, but he knows he cleanses. So I want to skip medical and dental history. So as we discussed about at the beginning, so pre-treatment photographs are important not only record keeping, but treatment planning. So you can see the pictures in MIP, in repose, and in smile. He does not show any lower teeth when he smiles. Also, his upper anterior teeth have severe wear with a slight reverse curve. This is the occlusal view. So we can see severe teeth wear on lower anterior teeth as well. So these are frontal views in MIP, protrusive, lateral excursive. You can see severe tooth wear in this slide as well. Based on full mouth radiograph and the periodontal evaluation, his bone level and his soft tissue are within normal range. So this is the list of the problems he has: tooth wear, unfavorable axis of tooth, short crowns, super eruption of the teeth, and then clenching. After discussion with the patient, he agreed to our treatment plan, which is a full mouth reconstruction. The treatment plan included the crown lengthening, endodontic treatment, casting post, implants, and the PFMs, and the tooth extraction. In terms of treatment sequence, it's the same as how we treat other patients. During the diagnostic phase, we tried to gather all information. With this information, we were able to treatment plan. In this specific case, patient lost posterior support, history of tooth wear, clenching. Also, we evaluated his current occlusal vertical dimension, rest vertical dimension, and facial profile and phonetics. Based on the comprehensive examination, his case is Dr. Turner's category 1. So no posterior teeth, unstable posterior occlusion, excessive wear with loss of occlusal vertical dimension. Based on his phonetics occlusal vertical dimension, rest vertical dimension, we conclude we should be able to raise his vertical dimension. We took impression for maxillary mandibular arch with arginate, took a CR record and CR record as well. We already knew his vertical dimension will be raised, so we mounted the diagnostic cast on the articulator with a faceable record. This is a tentative mounting in order to make a modified Lucia jig. In order to take another century relation and mount the diagnostic cast on the articulator for diagnostic wax up, first, we deprogrammed the muscle memory. We discussed about some techniques already. The technique I used for this patient is Lucia jig. First, we evaluate the occlusal vertical dimension and the rest of vertical dimension. And based on that, we determined the new occlusal vertical dimension. So we took a new CR record in predetermined vertical dimension with the pink tried record base. This pink tried record base as anterior wax rim. Sorry for, I'm like moving too fast. Sorry about that. Then we took new CR record in predetermined vertical dimension with the pink record base. The pink tried record base as anterior wax rim. And once we deprogram patient muscles with this modified Lucia jig, posterior bite registration was taken with the anterior stop. It's a little bit like a long, like a description, so that's okay. So you don't really need to follow everything. And we mounted the diagnostic cast with a modified Lucia jig with the 2 posterior bite registrations. Now diagnostic cast was mounted in new vertical dimension and the new central relation. Diagnostic wax up will be done in this new joint relation. So this is the diagnostic cast. So this is the diagnostic wax up cast on new vertical dimension and new central relation. So this is not great to wax up, but so we can see what we want to see. So you can see the diagnostic cast in MIP and diagnostic wax up in cast, diagnostic wax up cast in central relation. Based on our treatment plan, perio resident placed 9 implants on maxillary mandibular arches. Also, he did a clinical crown lengthening on maxillary anterior side after. There are some photos during the implant surgery. You see the guiding pins, like a drills, like a healing about the cover screws. So this is a panoramic radiograph after implant placement. So this slide shows after osseointegration. So another front view after osseointegration. So clinical crown lengthening was planned from the beginning of our treatment plan and then performed after osseointegration. Because we planned for the crown lengthening, upper the number 8 and 9 implant placed pretty deep. So when you look at the slides, even healing abutments are under the bone. So after crown lengthening, so we can see positive architecture bone around the implant. So right after clinical crown lengthening, number 7 and 10 crown height seems to be longer than before. Not a lot, but I can see that. So all implants are well osseo-integrated. It is ready to restore the case. So we made the putty external surface foam from the diagnostic wax up cast. Integrated was loaded into putty external surface foam, and the external surface foam was seated over the teeth before we started the case to make it sure. So this is the maxillary mock-up with the integrity material. So this is the mock-up for mandibular arch. We look at the aesthetics, evaluated the phonetics. We evaluate the swallowing as well. It seems that they look the same on the diagnostic cast and the intraorally. So patient didn't have any issue with that. Also, patient had pleased with how he looked like. So all teeth on maxillary and mandibular were prepped and temporized with the temporary implant cylinders. Mandibular arch provisionalization with the tooth prep was done in the morning. The same procedures, tooth preparation and temporary cylinder connection on maxillary arch in the afternoon. So both maxillary arch and the mandibular provisional crowns were delivered in a day, and he came back for follow-up, protrusive and then lateral exclusive. So he was doing okay. So he likes the like a temporary crowns. He likes how he looked like. Front view with the temporary crowns. Left profile with the temporary crowns. Right profile with the temporary crowns. So they look alike. So number 12 had root canal treatment done previously. So when number 12 existing crown was removed, around the 2 mm pedal was exist. So we made a casting post. So this is the custom tray for my full mouth impression. So personally, I like to bottom mold my tray before I remove temporary crowns. So benefit with this technique is when we take a final impression, those modeling compound board molding will function as a tissue stop. Also will function as a barrier to confine the PVS material inside of your tray. Your impression material will have more pressure into the gingival sulcus instead of flowing out of the underneath of your tray border. So this is the final impression. I think it turns okay. So here is the picture of the maxillary mandibular master cast. So now we need to mount the master cast on the articulator by cross mounting technique. I added another like cross mounting procedure. I wanna move forward. So I just added another cross mounting case to let you understand better. So temporal casts were mounted on the articulator before we do the cross mounting. So first, remove only maxillary anterior temporal crowns only. Anterior bite restoration was taken between anterior maxillary prepped tooth against anterior mandibular temporal crowns. And then maxillary posterior temporal crowns were removed, and the two other posterior bite restoration were taken with the anterior stop. In the lab, maxillary master casts can be mounted on the articulator with one anterior stop and the two posterior bite restoration. So you can see the slides. And then maxillary posterior, so temporal crown will be back, and the mandibular anterior temporal crown will be removed. And we take a bite restoration with a rigid material, which is a pattern resin. Then all maxillary and mandibular posterior temporal crowns were removed. Then posterior bite restoration were taken with the anterior stop. So now mandibular master cast should be able to be mounted against the maxillary master cast with one with the stop and the two bite restoration. So now these master casts and the temporary master cast should be interchangeable on the articulator each other. So with the cross-mounted master cast, the full contour wax up was completed. This is another one. So dental lab did a cutback for full contour wax up and casted the metal copings and built porcelain and baked them. This is the stage right before glazing and staging. So it is called the Bisc Stage. Before we cemented them, we decided to try in Bisc Stage porcelain to evaluate the margins into proximal contact and occlusion. So crown was cemented after grazing and the staining. Cementing 14 crowns is not easy. I just would like to share the sequence of 14 crowns cementation. So when you place all 14 crowns in one arch and evaluate into proximal contact before cementation, it's hard to tell. Even though it seems slightly loose, but when you start to cement one by one, you will realize interproximal contact is tighter than you think. So what I did was I cemented all posteriors first, and then cemented the centrals and canines. I cemented the lateral incisor last, but you need to make sure, you need to try in whether interproximal contact is tighter or not, and then make sure then you cement the lateral incisor the last. Front view with the final prosthesis. Sorry. The left profile with the final prosthesis. Right profile with the final prosthesis. So another CR record was taken for night guard fabrication. Full mouth reconstruction case. So we should let the patient wear the night guard in order to prevent the crown fracture, like maintaining soft tissue around, and then preserved like a temporomandibular joint. Cast mounted with a CR bite. Night guard was fabricated and evaluated on the cast when I got that back from the lab. Intraorally, night guard was adjusted until I can get even contact in centric or in eccentric. It shows a mutually protective occlusion, I think. So, so this is the before and after. So you see the patient is happy, so I'm happy too. So I already talk about this maintenance phase during the didactic course. So there are, so 1 hour lecture was too short to talk about this topic, but hopefully, so this presentation reminds you your prosthodontic course during your school. In graduate prosthodontics, so first year just start with the complete dentures first all the time. So my understanding is complete denture has prosthodontic foundations. So please enjoy treating complete denture patients. Then you will be confident, okay, to take care of this complex full mouth reconstruction case with either natural dentition or implants. You will have we are here so to educate the prosthetic residents and to collaborate with other specialties and general dentists in Texas. So definitely we are here to treat the patient. If you need us, please let us know. So lastly, I hope you enjoyed today my presentation. Have a good rest of day. So if you have any questions, please let me know. Sorry, I think the time is too tight. Thank you.
Thank you so much, Dr. Jeong. I think we have time for maybe one question.
Sure.
Are there any questions from anybody from our learning network?
So sorry again. So I should keep my timeline, but whatever reason, so it slightly took longer than I expect. I apologize for to every audience.
So I apologize. That was a very informative presentation.
So next time I will do better. So please invite me so one more time, please.
Definitely.
So there is a question on the chat for you, Dr. Jeong. It's asking by Dr. Brownlee, and it's asking approximately how long does a case take? Is it over 12 months?
So depending on the case, right? So I do not recall exactly how long it took this case. Yeah, I think that it took longer than a year. But to be honest, if I didn't know what I should have done at that time, probably timeline should be shorter than that, because I spent a few months to think about it because I'm trying to solve the problem. But a lot of full mouth reconstruction cases, depending on where we are going to refer the patient to sometimes go to ortho, sometimes go to the oral surgery. So it takes like a year when they come back to us again. So yeah, so I don't think it'll work within 6 months. In general, it takes like so a year. So this case, I say it took 1 year. Yeah, thank you for question.
Thank you so much. Since it's one, I would like to say thank you again to Dr. Jeong for your presentation. And please complete the post-session survey. And I believe the link was shared in the chat. And we hope to see you at our next session in November. Thank you again and have a great rest of the day.
Okay, thank you so much, everyone.